Welcome to another episode from the Veterinary Medicine Digest. Today, we delve into one of the most complex and critical aspects of veterinary medicine, the intricate world of calcium metabolism and the disorders that arise when its chief regulator, the parathyroid gland, malfunctions. We are focusing specifically on hyperparathyroidism in dogs, exploring everything from its primary presentation as a seemingly silent tumor to its secondary, and often more insidious, role in progressive chronic kidney disease. This is a topic that requires careful attention to detail, as small changes in blood chemistry can have cascading, life-altering effects throughout the body. The foundation of life, calcium homeostasis. To understand hyperparathyroidism, we must first appreciate the delicate balancing act that is calcium homeostasis. Calcium is not merely an element for strong bones. It is an inorganic element essential for survival, performing two primary functions, providing skeletal support and acting as a critical signaling molecule within cells. The truly active form of calcium, the fraction that our body actively regulates and uses for biological processes, is the ionized calcium. The total calcium measurement you see on a typical blood panel is actually composed of three fractions. The biologically active ionized calcium, accounting for about 56% in healthy dogs, the protein-bound calcium, mostly bound to albumin, about 34%, and the complex calcium, bound to various substances like phosphate, citrate, and bicarbonate, about 10%. The concentration of ionized calcium is incredibly sensitive to changes in blood acidity, or pH. If the blood becomes more acidic, more ionized calcium is released from its protein binders, increasing its concentration. Conversely, if the blood becomes more alkaline, ionized calcium concentration decreases. This biological sensitivity is why measuring ionized calcium directly is so important. Adjusting the total calcium value based on protein levels alone is unreliable and should be avoided, as these adjustment formulas do not accurately predict the biologically active ionized calcium concentration. This precise balance is governed primarily by three hormones acting on three major target organs: the bone, storage; the kidney, excretion and activation; and the small intestine, absorption. The parathyroid hormone is the chief regulator of calcium and phosphorus levels. When ionized calcium dips too low, the chief cells of the parathyroid gland synthesize and release parathyroid hormone within seconds. The immediate effects of this hormone are to increase calcium reabsorption in the kidney tubules within minutes and to mobilize stored bone calcium, also within minutes to hours. The second major hormone is calcitriol, the biologically active metabolite of vitamin D. Parathyroid hormone indirectly enhances intestinal calcium absorption by stimulating the synthesis of calcitriol in the kidneys, a process that usually takes about 24 hours. Calcitriol is incredibly potent, causing a 100-fold increase in bone calcium resorption and enhancing intestinal calcium absorption threefold compared to its precursor, cholecalciferol. The third player is calcitonin, synthesized in the thyroid gland. Calcitonin works to decrease serum ionized calcium following rapid rises. However, calcitonin is considered an emergency hormone whose biological significance in the chronic regulation of calcium concentrations is limited. Primary hyperparathyroidism, the autonomous gland. Now, let's address the central topic, primary hyperparathyroidism, often referred to simply as PHPTH. This endocrine disorder arises when one or more parathyroid glands begin to function autonomously, producing and secreting excessive, inappropriate levels of parathyroid hormone despite already having elevated concentrations of serum calcium. In dogs, the vast majority of primary hyperparathyroidism cases are caused by a solitary parathyroid adenoma. Less common causes include multiple gland adenomas, hyperplasia of one or more glands, or, rarely, a carcinoma. Parathyroid carcinomas account for only about 5 to 10% of cases. Primary hyperparathyroidism is overwhelmingly a disease of older dogs, with over 95% of affected animals being 7 years or older. The mean age at diagnosis is typically around 10 to 11 years. While many breeds can be affected, there is a distinct overrepresentation in certain dogs, most notably the case haunt. In some studies, case haunts account for as high as 20% of cases, demonstrating an odds ratio of 50.7 for having the disease compared to other breeds. This suggests a heritable, autosomal dominant mode of inheritance in this breed. The silent threat, clinical presentation. One of the most insidious aspects of primary hyperparathyroidism is its subtle clinical presentation. In a large number of cases, owners report no clinical signs at all, even after they are educated on what symptoms to look for. In one study of 210 dogs, hypercalcemia was identified in 42% of cases incidentally, often during routine geriatric screening or pre-anesthetic testing for procedures like dentistry. Since the disease affects older dogs, owners often mistakenly attribute mild signs to the normal aging process. When clinical signs are present, they are often vague and nonspecific. The most common abnormalities reported are those related to water balance and the urinary system. Due to the high circulating calcium levels, the kidneys develop a reversible form of nephrogenic diabetes insipidus, where calcium acts as an antagonist to antidiuretic hormone, disrupting the urine concentrating mechanism. This results in polyuria, increased urination, and compensatory polydipsia, increased thirst, signs present in nearly half of affected dogs. Urinalysis typically confirms this, showing diluted urine with a urine-specific gravity, often lower than 1.020. Other common, yet nonspecific, signs include weakness, decreased activity, lethargy, and decreased appetite. More severe neurological signs like seizures, depression, or coma are rare. In fact, the resolution of seizure activity after surgical correction of hypercalcemia in one German Shepherd dog strongly supported the hypercalcemia itself as the cause of the neurological signs. A significant complication resulting from the persistent hypercalcemia is the formation of uroliths, or urinary stones. The combination of hypercalciuria, excess calcium in the urine, and increased urine pH facilitates stone formation, frequently composed of calcium phosphate or calcium oxalate. Urinary tract infection, or UTI, is also common due to these uroliths. In one large study, nearly 30% of dogs with primary hyperparathyroidism had a urinary tract infection at the time of diagnosis, and 31% had concomitant cystic calculi. This high incidence of urinary disease often serves as a key reason to pursue curative treatment, even in otherwise asymptomatic patients. On physical examination, most dogs with primary hyperparathyroidism appear unremarkable. Palpation of an enlarged parathyroid gland is extremely rare due to the gland's small size, 4 to 8 millimeters in diameter, and its location beneath layers of muscle in the neck. Pathophysiology: the uncontrolled drive. In a healthy animal, rising ionized calcium levels immediately suppress parathyroid hormone secretion. However, in primary hyperparathyroidism, the abnormal gland secretes parathyroid hormone autonomously, ignoring this crucial negative feedback loop. The consequence of this uncontrolled parathyroid hormone release is persistent hypercalcemia, which is the hallmark of the disease. The sustained high parathyroid hormone levels continually stimulate bone resorption, leading eventually to thinning of the cancellous and cortical bone. While the classic skeletal lesion, known as fibrous osteodystrophy, is common in human primary hyperparathyroidism, it is rare in dogs. Parathyroid hormone also severely inhibits phosphate reabsorption in the kidneys, leading to excessive phosphate loss in the urine and resulting in hypophosphatemia or phosphate concentrations at the very low end of the normal range. In fact, if a hypercalcemic dog is not hypophosphatemic, it should raise suspicion for concurrent renal failure. The diagnostic confirmation of primary hyperparathyroidism relies on demonstrating this abnormal hormonal response. You must have inappropriate levels of parathyroid hormone, meaning the concentration is normal or elevated, concurrently with an elevated ionized calcium level. In up to 73% of cases, the parathyroid hormone concentration measured by immunoradiometric assays might fall within the established laboratory reference range. However, in the context of hypercalcemia, even a normal parathyroid hormone level is considered inappropriate because the high calcium should have suppressed parathyroid hormone completely to an undetectable level. To rule out malignancy as the cause of hypercalcemia, the parathyroid hormone-related protein assay is crucial. This protein is frequently secreted by tumors, such as lymphoma or anal sac apocrine gland adenocarcinoma, to mimic the effect of native parathyroid hormone, causing humoral hypercalcemia of malignancy. In a dog with primary hyperparathyroidism, the parathyroid hormone-related protein level should be undetectable or well below the reference range. Differential diagnosis: navigating hypercalcemia. Hypercalcemia is serious, and diagnosing its cause determines the appropriate prognosis and treatment plan. While primary hyperparathyroidism is a critical cause, it is not the most common cause of hypercalcemia in dogs. In dogs, the most common cause of hypercalcemia is neoplasia. In fact, hypercalcemia of malignancy accounts for well over 50% of cases identified in retrospective studies. The most frequent malignancies associated with high calcium are lymphoma, particularly T-cell lymphoma, and anal sac apocrine gland adenocarcinoma. Other key differentials include: 1. Chronic kidney disease. This is a diagnostic challenge because hypercalcemia can be both a cause and a consequence of kidney disease. Typically, dogs with chronic kidney disease and hypercalcemia will also show increased phosphorus concentrations, hyperphosphatemia, in contrast to the hypophosphatemia seen in primary hyperparathyroidism. However, the biologically active ionized calcium may be normal or even low in many cases of chronic kidney disease. 2. Hypoadrenocorticism. Addison's disease. About 30% of dogs with this condition develop hypercalcemia. It should always be excluded, often requiring an adrenocorticotropic hormone stimulation test for a definitive diagnosis. 3. Hypervitaminosis D. Vitamin D toxicity usually results from the ingestion of rodenticides containing cholecalciferol or excessive dietary supplementation. This causes severe hypercalcemia and often concurrent hyperphosphatemia, quickly leading to acute renal failure. Imaging and surgical planning. Once primary hyperparathyroidism is suspected based on hormonal assays, imaging becomes vital for localizing the offending gland and excluding other diseases. Thoracic and abdominal radiographs or ultrasonography are performed primarily to look for signs of malignancy or kidney stones. Cervical ultrasonography is considered routine and is highly effective for identifying the abnormal parathyroid gland. The parathyroid mass typically appears as a solitary, well-margined, hypoechoic to anechoic structure adjacent to the thyroid gland. The median diameter of these masses is typically around 6 millimeters. Although a presumptive diagnosis can sometimes be made based on size, neoplasia usually over 4 millimeters, hyperplasia usually under 4 millimeters, histopathology is required for a definitive classification. Failure to locate a mass does not definitively exclude primary hyperparathyroidism, but it does make the diagnosis less likely. The success of this imaging relies heavily on the operator's skill and experience. Curative treatment modalities. The prognosis for dogs treated for primary hyperparathyroidism is generally excellent, as most lesions are benign. Treatment is considered curative and should be pursued regardless of whether clinical signs are overtly obvious, as resolution of even subtle signs improves the patient's quality of life and removes the risk of long-term complications like urolithiasis. Before definitive treatment, dogs with severe hypercalcemia, total calcium greater than 14 milligrams per deciliter, or showing neurological/cardiac signs, require acute management. The initial goal is aggressive intravenous fluid therapy, typically using 0.9% saline, as its high sodium content promotes diuresis, encouraging the kidneys to excrete calcium. If hypercalcemia persists after rehydration, a diuretic such as furosemide may be added to promote renal calcium excretion. Glucocorticoids, which are often highly effective for treating hypercalcemia of malignancy, especially lymphoma, should generally be withheld until a definitive diagnosis of primary hyperparathyroidism is confirmed, as they can interfere with the diagnosis of malignancy. The definitive treatment methods for primary hyperparathyroidism are: 1. Surgical parathyroidectomy. Traditional parathyroidectomy via bilateral neck exploration has long been the standard of care, offering a cure rate of approximately 95%. The surgery involves carefully exposing all 4 parathyroid glands through a ventral midline approach to identify and remove the autonomous gland, while sparing at least one healthy gland to maintain calcium homeostasis and prevent permanent hypoparathyroidism. Preservation of blood supply to the remaining tissue is critical. More recently, a minimally invasive parathyroidectomy technique has been described, guided by preoperative ultrasound localization of the affected gland. This lateral approach involves a much smaller incision and focused dissection, resulting in significantly less patient discomfort and potentially decreased surgical time compared to traditional bilateral neck exploration. In a study using this minimally invasive approach, the cure rate was 93.3%, comparable to the traditional method, with a lower rate of postoperative hypocalcemia reported. The median surgical time for unilateral removal was reported as 26 minutes. During surgery, intraoperative parathyroid hormone assay testing can be utilized. This involves measuring parathyroid hormone levels before and about 30 to 45 minutes after the presumed abnormal tissue is removed. A drop in parathyroid hormone concentration greater than 50% confirms that all hypersecretory tissue has been excised, providing immediate confirmation of a surgical cure. 2. Percutaneous ablation techniques. For owners seeking a less invasive alternative, 2 ultrasound-guided techniques exist: ethanol ablation and radiofrequency heat ablation. Ethanol ablation involves injecting ethanol, a caustic substance, directly into the parathyroid mass under ultrasound guidance to cause coagulation necrosis. In successful cases, hypercalcemia typically resolves within 1 to 4 days. While effective in many dogs, success rates around 72 to 85%, concerns exist about the leakage of the chemical damaging surrounding tissues, potentially leading to nerve damage or laryngeal paralysis. Radiofrequency heat ablation uses a fine needle to apply radiofrequency energy, converting it into heat at the tip, causing thermal necrosis of the mass. This method has a high success rate, around 90% in one study, but small masses, under 5 millimeters, may be poor candidates for this procedure. Compared to surgery, both ablation techniques typically require a much shorter anesthesia time, which can be a significant advantage, especially for older dogs with concurrent diseases. However, ablation carries disadvantages, including a higher risk of recurrence, lower success rates overall than surgery, the inability to obtain a definitive histological diagnosis of the excised tissue, and a higher risk of damaging the recurrent laryngeal nerve. The post-treatment challenge, hypocalcemia. The most crucial aspect of postoperative care following curative treatment for primary hyperparathyroidism is managing hypocalcemia. This complication occurs because the chronic excess of parathyroid hormone secreted by the tumor suppressed and atrophied the patient's remaining 3 or sometimes 2 normal parathyroid glands. Once the autonomous tumor is removed, the parathyroid hormone level plummets, and the atrophied normal glands cannot immediately secrete enough hormone to regulate calcium. Hypocalcemia is reported in a large percentage of treated dogs, between 25 and 71%. It usually manifests between 1 and 7 days post-treatment, most commonly between 3 and 6 days. Clinical signs of severe acute hypocalcemia are neurological and neuromuscular, including muscle tremors or twitching, ataxia, unsteady gait, facial rubbing, nervousness, and critically, seizures and muscle tetany. One dog in a surgical series tragically died from clinical hypocalcemia because the owner was non-compliant with postoperative instructions regarding medication. To prevent this life-threatening complication, intensive monitoring and proactive therapy are mandatory, especially in dogs with higher preoperative calcium levels, total calcium greater than 15 milligrams per deciliter. Management involves 2 key components. 1. Calcium supplementation. For acute, life-threatening drops or clinical signs, a slow intravenous bolus of 10% calcium gluconate is administered, carefully monitoring the heart rate and electrocardiogram for signs of cardiotoxicity, such as bradycardia or shortened QT interval. Because the effect of a bolus is short-lived, it must be followed by a constant rate infusion of elemental calcium until oral therapy takes effect. 2. Vitamin D supplementation. Because oral calcium and vitamin D therapy can take 24 to 96 hours to become effective, the rapid-acting metabolite calcitriol is the preferred supplement, often started prophylactically the morning before surgery. Calcitriol has a rapid onset of action, 1 to 4 days, and a short half-life, which is safer than older, longer-acting vitamin D analogs should toxicity occur. The goal is to maintain calcium concentrations at low normal levels to prevent clinical signs while encouraging the remaining parathyroid tissue to resume function. Dogs should ideally remain hospitalized for 5 to 7 days post-treatment for rigorous monitoring of their calcium status. The secondary challenge, chronic kidney disease. While primary hyperparathyroidism is about an autonomous tumor, hyperparathyroidism also occurs commonly as a secondary consequence of chronic illness, most notably renal secondary hyperparathyroidism. This condition is considered an inevitable complication of chronic kidney disease. The pathogenesis is multifactorial. As kidney function declines, the glomerular filtration rate decreases, leading to phosphate retention, hyperphosphatemia. This retained phosphate, along with the loss of functional kidney mass, leads to decreased activity of the key renal enzyme, 1-alpha hydroxylase. The consequence is severely reduced production of calcitriol, the active vitamin D metabolite. Both the high phosphate and the low calcitriol strongly stimulate the parathyroid glands to increase parathyroid hormone secretion. This compensatory increase, or secondary hyperparathyroidism, is initially adaptive as it helps restore calcitriol and calcium concentrations in early stages. However, as the chronic kidney disease progresses, the parathyroid gland undergoes hyperplasia. This glandular enlargement can become resistant to normal regulation, leading to persistently high, toxic levels of parathyroid hormone. These persistently elevated parathyroid hormone levels are extremely toxic, acting as a uremic toxin that affects multiple organ systems throughout the body because of the widespread distribution of its receptor. Toxic effects include central nervous system depression. Elevated parathyroid hormone is implicated as a major cause of uremic encephalopathy, causing clinical depression and decreased alertness. In surveys of veterinarians treating chronic kidney disease, 80 to 85% agreed that patients treated appropriately seemed brighter, more alert, and more interactive with their owners. Anorexia and metabolic dysfunction. Excess parathyroid hormone is a factor in uremic anorexia. It impairs carbohydrate metabolism by increasing muscle cell resistance to insulin and impeding insulin secretion. 77 to 84% of veterinarians surveyed reported improved appetite in calcitriol-treated dogs and cats. Physical weakness and cardiac damage. Parathyroid hormone excess causes myopathy, muscle disease, by forcing calcium into muscle cells, leading to toxic levels that deplete adenosine triphosphate, resulting in muscular weakness and decreased physical activity. Furthermore, parathyroid hormone damages the myocardium, promoting myocardial calcium accumulation and leading to left ventricular hypertrophic cardiomyopathy, a severe cardiac lesion. Anemia. Elevated parathyroid hormone contributes to anemia through multiple mechanisms, including causing fibrosis of the bone marrow, inhibiting erythropoiesis, and increasing the osmotic fragility of red blood cells, thus diminishing their lifespan. Progression of kidney disease. High levels of parathyroid hormone promote nephrocalcinosis, calcification of the kidney tissue, which directly contributes to the progressive and self-perpetuating loss of renal function. Therapeutic strategies for secondary hyperparathyroidism. The management of renal secondary hyperparathyroidism is crucial, as both elevated parathyroid hormone and high phosphate levels correlate with the progression of chronic kidney disease and decreased survival time. The foundation of management is phosphate restriction, achieved through a clinical renal diet and sometimes intestinal phosphate binders, like calcium carbonate or aluminum hydroxide. It is considered the single most important therapeutic measure, aiming to maintain plasma phosphate below 6 mg per deciliter, depending on the stage of kidney disease. Controlling phosphate is a vital prerequisite because high phosphate concentrations can interfere with the transcription-inhibiting actions of calcitriol on the parathyroid gene. Once phosphate is controlled, calcitriol therapy, the active vitamin D metabolite, can be instituted. Although calcitriol must be used carefully due to the risk of causing hypercalcemia and hyperphosphatemia, which would worsen chronic kidney disease, low daily oral doses are safe and highly effective. Calcitriol works primarily by binding to the vitamin D receptor in the parathyroid glands, acting as a powerful inhibitor that suppresses parathyroid hormone synthesis and secretion. Importantly, low-dose calcitriol therapy, when started early in renal failure, is highly effective in preventing the parathyroid gland hyperplasia that makes advanced cases so difficult to control. Veterinarians surveyed reported that calcitriol-treated patients seem to have longer lifespans compared to similarly uremic patients treated previously. In advanced cases with severe hyperplasia, an intermittent, pulse dosing strategy of calcitriol may be employed. This involves giving much higher doses, typically twice per week, to achieve high peak blood levels without causing the hypercalcemia that would occur with daily dosing. An alternative approach involves using newer synthetic vitamin D analogs, such as Paricalcitol. These analogs were developed hoping to maintain the parathyroid hormone-suppressing benefits of calcitriol while having fewer hypercalcemic side effects. A recent study in dogs with chronic kidney disease showed that paricalcitol effectively decreased parathyroid hormone concentrations by 22% and stabilized renal proteinuria. However, this study also demonstrated that paricalcitol is not without risk, as ionized hypercalcemia developed in over half of the treated dogs, necessitating a dose reduction. Paricalcitol treatment also caused an increase in phosphate concentrations and in fibroblast growth factor 23, a phosphaturic hormone associated with mortality. Therefore, similar to calcitriol, paricalcitol therapy requires careful case-by-case consideration and intensive monitoring of calcium and phosphate. Whether dealing with the autonomous gland of primary hyperparathyroidism or the compensatory overactivity of secondary hyperparathyroidism, achieving and maintaining calcium and phosphate homeostasis is paramount to ensuring the health, longevity, and quality of life for our canine patients. The tools for diagnosis, localization, and definitive treatment are becoming increasingly precise, offering excellent outcomes when these complex hormonal disorders are addressed promptly and effectively. Thank you for listening. The titles for the reference papers are in the video description. From Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging.